Hey guys, am I audible and visible? I am not able to see me in the app, so I hope I'm audible and visible. I'll just refresh once again. Hey everyone, good evening. Okay, great. So welcome back everyone to PW Med. Myself, Dr. Ranjit. So I am here to take pathology for you, and I hope you are having a good experience in your second year. Just to start the live chat, like, can you guys comment that which month of the second year you are in? If you are just started or if you have been like 1 month, 2 months, just to make sure that we are all aligned on the same page. And I just want to check whether the comment system, everything is working. Okay. So I hope everything is going good from the end, from the tech end, everything is fine. Great. Okay. Thank you for your response. So we will be starting with the first chapter of cell adaptation. I'll tell you exactly how I will pace my lectures. In Robbins, if you look, my main goal is to read Robbins. My main goal is to make sure every one of you is going to read Robbins, right? Great, great, thank you. So we are going to go with your CBME curriculum. If you look at Robbins, the first chapter of Robbins, you will have the genetics, you'll have few of the growth factors, cell cycle, everything given. If you look at the CBME curriculum, this part of whatever is there in the initial part of the Robbins is being somewhere else, fine. So what I'll be going towards is before every chapter, before every topic, I'll tell you what all competencies I'll be covering in that lecture. Because your entire curriculum is based on competency based medical education. Your entire second year syllabus is divided into competencies. I'm sure in your first year also you must have done the same thing, right? So we'll be going with the same way. Today I'll be discussing just a brief introduction to break the ice, the role of a pathologist in diagnosis and management, and our main focus will be based on this. Like what I'm going to discuss today majorly is on cell adaptations, atrophy, hypertrophy, hyperplasia, metaplasia, and dysplasia. Fine. Okay. I hope you are ready. So just to break the ice again, how many of you have bought Robbins? Can anyone comment that have you bought Robbins? How many of you got Robbins? If you say why also is enough for me for yes, you need not comment yes, right? The first and the foremost goal is how to read Robbins. Quite a few students have asked me, should I read Robbins? The absolute answer is yes. You have to read Robbins, know the textbook, right? I'm sure that you must have had few seniors who you must have told that Robbins you can read, but you will not score well, right? The Robbins you can read, you will not score well. So there are quite a few seniors who would have advised you against that. Quite a few seniors said that Robbins is very, very big. Don't read that. You will not be able to complete. Robbins is not needed. It's fine. Okay? Vala Vishal, tell me what is your concern in Hindi and English. I'll tell you. I'll just sort you out there. मेरा हिंदी थोड़ा खराब है, so only I'm using English to explain. So if you have any doubt, I'll intervene and let's go slowly. Fine. Okay. So the goal here is to read Robbins, and you guys have to read Robbins if you're in your second year of MBBS. So how to read Robbins is main important. If you read from line to line, like in 11th standard, you can never complete Robbins. Okay, that's a concern here, right? You can never ever complete Robbins. So here, I tell you, like, if you had take any disease, see general pathology. When you take anything in general pathology, I want you to spend more time and read, right? Whatever you read in general pathology is very, very important. I'll tell you an easy example why this is very, very important. Generally, students start with, even few colleges start with hematology. That I would say is a wrong way of approach. You should not start with hematology. You should start with general pathology only, right? Because inflammation. Am I right in saying that? Just put on the comment box. Am I right in saying that brain also can have inflammation? Tip of the toe also can have inflammation? Yes. So if I read inflammation, I can apply the same concept to brain. I call it meningitis encephalitis. If it's the meninges or the parenchyma, I can put it in the tip of the toe and I can call it paranoia. So for me, general pathology is very important. Apoptosis, necrosis, I'm sure you must have heard that. That happens in every organ in my body. Genetics, genetic disorders is there in every organ. Liver has genetic disorders, heart has genetic disorders, kidney has genetic disorders, brain has genetic disorders, right? So if I learn general pathology, I can take the same concepts, put in liver, complete liver pathology, put in GIT, complete GI pathology. And the most important thing for me is required is base. So general pathology is base. Spend maximum time on this. If your college has started hematology, it's fine. Read with me with general pathology. You will easily align and you will easily understand about hematology as well and systemic pathology. Then I'll go to systemic pathology and hematology, right? And the way to read Robbins is, like I said, not line by line. You form a template. I want you to form a template for every disease you're going to read going forward. See, general pathology is different. Systemic hematology deals about diseases only. In general pathology, I'll give you a template, but when you go to systemic pathology and hematology, I want you to use this template. Okay, since you're very early, these definitions are also a part of your CBMA curriculum. What do you mean by etiology? Can anyone comment that, okay, this is what I think about etiology? What is the etiology? In simple words, what do you mean by etiology? Etiology means nothing but the cause. Let's take COVID for example. The etiology is the coronavirus. That's the cause, right? Let's take any other disease. Let's take hypertension for an example. I have multiple etiological risk factors there, right? So etiology means whatever causes the disease, I'm going to term them as etiology, right? Sometimes I will use a term called as risk factor. I want you to understand all these terminologies now itself so that you don't have a problem. Perfect. Risk factor, when I use, it is not only etiology, it's just providing an extra risk. Can I say diabetes? You must have definitely heard about diabetes. Some of your family members also have diabetes. Diabetes has single etiology or risk factors. Risk factors, right? Sedentary lifestyle, a risk factor. Eating too much of carbohydrates, a risk factor, right? Etiology is equivalent to cause for most of the diseases. When I talk about risk factor also, it comes under the etiology only. Risk factor and causation is not the same. It's two different things. Cancer doesn't have cause. Cancer, most of them have risk factors. Not eating a proper food in correct timing, risk factor for gastritis, right? So you should know the difference between risk factor and etiology, cause, and both of them come under etiology only. Let's take pathogenesis. Okay, I'm going to explain you all these terminologies using the same example, COVID, because that's a recent disease which is in the pipeline, right? So COVID never ends, it keeps on coming again and again. So what is the pathogenesis of COVID? The way a COVID virus causes the lung damage, that is my pathogenesis, right? It's the way by which any disease will cause damage to the body. Damages the body, I'm going to call them as pathogenesis. The way COVID destroys my lung is pathogenesis. The way diabetes, I'm having hyperglycemia, more sugar levels, is the pathogenesis, right? When I come to clinical factors, I'm sure you know about clinical features. In COVID, what do you think is a clinical feature? But some of you might have had COVID also, or your family members might have had COVID. Can anyone tell me, comment any one clinical feature which comes to your mind in COVID? Any one clinical feature. So clinical feature tells if it's COVID, cough is a clinical feature, breathlessness is a clinical feature, right? So to put in simple terms, my disease has caused a pathogenesis inside the body. How the patients present to me is a clinical feature, right? As simple as that. Any disease. If it's blood sugar, the patient's having hyperphagia, eating more, urinating more is a clinical feature, right? That's what does clinical feature mean. Investigation, again with same COVID, your RT-PCR. All of us must have known about RT-PCR, right? The way I'm going to diagnose. There is where microbiology comes, biochemistry comes, pathology comes, right? So here, how do I diagnose? Just since we are talking about COVID, RT-PCR is my investigation. Management, either rest for mild cases, hospitalization for moderate to severe cases. Complication, you have a lung complication. How many of you have heard about a complication of COVID called as ARDS? Can you comment yes or no? You must have heard about a complication called as ARDS, right? Acute respiratory distress syndrome, or my lung failure. That's my complication of COVID, followed by death. Since I'm taking COVID, I'm talking about this, followed by death, right? So this template is the only thing I want you to fill up from now till you practice medicine. See, if you fill this template in any disease, you need not remember everything in Robbins line by line. If you know etiology, if you know pathogenesis, if you know clinical features, investigation, management, complication, that is enough to clear MBBS, to clear your next exam, to be an amazing doctor. In addition, should I remember the gene names? Some of them, yes. Should I remember the gene number? Some of them, yes. Those things will add on just for an MCQ point of view. See, I work in genetic diagnosis. I diagnose PCR. I diagnose COVID PCR. I diagnose many genetic diseases. Honestly speaking, I don't know the gene numbers. I don't want you also know the numbers, but a few irritating people who create questions out of it, right? So if I'm able to take care of these, you can take care of entire medicine. Don't worry about it, right? So this template, remember, till you practice medicine, only these things should be ticked. If I tick all of these boxes, I know how to diagnose a patient, how to manage a patient in real life. MCQ exam shouldn't be a worry at all, right? Okay, with that note, let's go on. So the first CBME, the thing for you is the role of pathologist in a disease, because this is one of the thing like your guidelines to, you have lots of CBME points, right? One of them is role of a pathologist in a disease. Can any of you guys comment, what do you think a pathologist does apart from just sitting and looking into a microscope, which we are never going to understand what it is? We always look at this outside the slide, right? What do you think a pathologist does? Any random thing which comes to your mind? If you are just even going to comment that they're going to eat and sit simply, I'm not going to be offended at all. What do you think a pathologist does? The role of pathology in a disease is in diagnosis. I'm going to help in diagnosis. Pathologists are not involved in management. My only goal is diagnosis. I help in the diagnosis of a disease, any disease. Biochemists also help the same. Microbials also help the same. Pathologists also help the same. Fine. Perfect. Osama is right. Pathologists identify or diagnose a disease. Perfect. Right. So once I have diagnosis, by what all modalities a pathologist helps in diagnosis? Have you ever been to a pathology lab in your college? How many of you guys have gone to the pathology lab in the college? Have you been there? If so, comment why. So if you have been to the pathology lab, there are multiple streams of pathology, right? There are multiple streams of pathology. I don't diagnose anything with one investigation. There will be multiple investigation, right? So I have a subdivision called as hematology. The hematology deals with everything in your blood, be it an anemia or a leukemia. Tiny problem to a cancer. Everything is done by hematology department, right? That's one it is. The second department, I have something called as cytology. That's the second department. You must have heard about thyroid. You must have read about thyroid in anatomy and physiology, right? So every thyroid disorder is being done by cytological examination. We have a test called as an FNAC, right? So we have a test called as an FNAC. FNAC stands for fine needle aspiration cytology, right? I use a very tiny needle. I cannot take a biopsy of thyroid. Okay, that's why I use a technique called as a fine needle aspiration cytology. Okay, it's FNAC, fine needle aspiration cytology. Can anyone comment below why I cannot take a biopsy of thyroid? I told that I cannot take a biopsy of thyroid. Tell me why. Okay, can anyone comment on that? Okay, that's FNAC. Apart from that cytology, I'll answer the question soon. Apart from that, have you heard something called as a pap smear? You must have read about pap smear, right? The way to screen cervical cancer. It's a smear technique. That also comes under cytology, right? I have hematology, which takes care of everything related to the blood disorders, be it hemophilia, be it leukemia, be it anemia. It's going to be by hematology. And cytology, I have these two things, right? I'll answer this question. Perfect. Sana is right, bang on the answer, right? It has a very rich blood supply. Perfect. See, why I asked you this question is very, very good, right? Amazing. Why I asked you this question is, what happens is for you guys, when you're young, you have to start asking questions again and again and again. Whatever it is, anything given to you, you have to ask questions. Only when you ask questions, answers will come. Now I'll ask a question back. Three of you guys have said that it has a very rich blood supply. Can I say even my skin has rich blood supply? It does. Spleen, rich blood supply or not? Very high blood supply. But we do biopsy of the skin. We do biopsy of the renal. We do biopsy of the kidney. We do biopsy of spleen. We do biopsy of liver. Then why thyroid? Your answer is partly right. I'm not denying at all. Your answer is partly right. But still, I don't have a perfect answer. I don't have a perfect answer. The reason is the location. Let's say I'm taking a skin biopsy. It will bleed. It will definitely bleed. I can compress and stop the bleeding. Can you compress thyroid? Compress and see, you will know the answer. That's why I don't go for a much invasive test. I go for a minimally invasive test. I cannot compress the structure because I'll choke the patient. The patient will die. That's the reason it is vascular, perfectly right. But many vascular organs I can take biopsy here because of the vitality. I cannot compress the structure, right? Okay, we'll come to the next. That's the first part of it, right? Uh, Raj, capsule, uh, we'll not go into the depths of it because capsule is definitely one of the concern, but the main location is the practicality, right? I will not be able to compress and stop the bleeding. That's one concern, fine. Next, we'll come to the third thing, which is histopathology. Okay, okay. The third one is histopathology. So when I take histopathology, all the biopsies, has any of your family member underwent a biopsy? For any cancers, we need a biopsy for diagnosis, right? Anything which is done with the form of a biopsy, it will come into histopathology. You take a tissue from my body, it will come into histopathology, right? That's my third vertical in pathology. The fourth and the newest vertical is genetics. Genetics is partly divided between microbiology, biochemistry, and pathology as well. Because if it's an organism like COVID virus, microbiology comes inside, right? If it's purely something related to cancer genetics, pathology comes inside, right? So these are the four verticals of pathology. The role of the pathologist, like you said, is to diagnose. My role is to diagnose in the hospital front, research when I have something new. Pathologists do the research, right? Research is also one of the important scope of a pathologist. Any new thing, when you take COVID, I'm using COVID examples. I'll keep on using COVID examples because it's very, very common and very, it's fresh in your memory, right? During the first wave of COVID, we didn't know anything about COVID. So what happened after that is the second wave after the first wave of COVID, what happened is they did post-mortem. You must have wondering that post-mortems are done only by forensic people. No, post-mortems are done by pathologists also, right? Ankita, I'll answer your question just in a minute, right? So in post-mortem, we looked into the microscopy of the lung. We looked in the microscopy of the lung. Only then we were able to say, okay, the problem is ARDS. That's why in the second wave of COVID, we had a series of tests and then we were able to say, we're able to devise a treatment. Till that, I was not able to know the treatment, just paracetamol or random treatment, ivermectin, any random thing, right? So here is where comes research. Any new diseases, pathologist comes into research. Second, let's say that Dr. Ankit must have told you definitely about few drugs in the yesterday's class, right? Let's assume he must have, I also listened to the class, he did talk about digoxin. So for digoxin, when they discover digoxin, they have to know that digoxin works in heart failure. There, a pathologist intervenes, whether the problem is getting solved or not, right? In drug discovery also, there is little bit involvement of pathologist. The major role is with pharmacologist. Drug discovery and action, pathologists do play a role little bit. And any new advances comes, that's a research segment of pathology, right? Ankita, coming back to your question, biopsy versus FNAC. Let's take this a tissue. Okay, let's take that's thyroid. A biopsy will cut a core of a tissue, a bigger tissue, so that when I take it outside, I'll get such a big tissue, which means it's damaging it more. FNAG, on the other hand, will use a needle. Have you got injections, normal injections, vaccinations? I will use the same needle. That needle will be very thin. The only difference is FNAC needle will be like this. I won't damage the tissue at all. Biopsy needles will be very thick. That's the only difference between FNAC and a biopsy. Okay. Okay. Abhi, the role of a pathologist in a post-mortem is a pathologist takes care of anywhere I do post-mortem. The role of pathologist is for all the medical deaths. That's the role of pathologist. I'll tell you what does a medical death mean, right? Let's assume a patient came to the emergency casualty without any cause, suddenly brought dead. It could be by poison, it could be by homicide, it could be by heart attack also. If I'm having a medical death, pathologist comes and says, what is the reason for that? For every medico-legal cases, forensic medicine comes, rape, hanging, all are medico-legal problem, right? But for medical death, pathologist intervenes. It's always a correlation. Forensic medicine does the postmortem, gives the organ to me. I look into the microscope and say, okay, this is how the patient has died. Okay, it's always a correlation. That's how pathologists help in death. And for any new diseases comes, I learn the disease with postmortem. In COVID, I cannot go and take a lung biopsy and the peak of COVID. So people die. I look at the dead tissue and death teaches the living, right? Okay. Rajeshwari Ghosh, in FNAC, if you use a larger needle, there'll be little bit of fluid collected anyway. But my concern is not the fluid, the cells. Fluid will be there, serum will be there. I'll look at the cells and then I'll look, give the diagnosis, right? When you go to FNAC, we'll learn about FNAC, fine? The role of pathologist is simple. So the first thing for you in the CBME curriculum is what does a pathologist do? They help in diagnosis, and these are the ways by which I help in diagnosis. And then I have a little bit amount in research as well. And one more important role of pathologist, which of late is very important, is prognosis. Can anyone comment what do you mean by prognosis? Anyone, whatever comes to your mind. I'm sure you must have heard about this thing, right? Pathologist not only helps in diagnosis, they also help with prognosis. So prognosis means to tell how well the patient will respond to the treatment. Okay, no mention. Okay, that's what I mean by prognosis. That is also to some extent done by pathologists, right? I'll give you an example. Perfect. Outcome of the disease. That's very, very important, right? So how well the patient will respond to a treatment. Let's say, how many of you guys have heard about a disease called as an CML or chronic myeloid leukemia? Some of you at least must have heard about a disease called as CML or chronic myeloid leukemia, right? And I'm sure everyone must have read about breast cancers, right? You must have definitely read about breast cancers. Let's say a patient has a breast cancer, comes to the pathologist. What I do is I take a biopsy and tell it's a breast cancer. I don't stop with that. After diagnosing breast cancer, I use some stains. I use some markers or stains. The stain commonly done stain are ER, PR, or 2 These are the three commonly done stains. We'll read them, revisit them when we go to breast cancer again and when we go to neoplasia. ER stands for estrogen receptor. PR stands for progesterone receptor, and HER2/neu is a stain, right? So when I have a breast cancer stain, I'm saying that it is ER positive, PR positive. Can I give hormones? Will that kill the cancer? If it's ER is estrogen receptor, if I give an estrogen receptor blocker, will the breast cancer stop growing? Is my statement correct? Possible, right? If HER2/neu is positive, I have a drug antibody against HER2/neu. We'll read the antibodies when Ankit sir goes to the pharmacological part, right? So I don't just tell me the diagnosis. I don't just tell it's a breast cancer. I also tell these are this positive. So probably use it for treatment. Perfect. Sahil is right. CA15-5 also, right? That's for different cancers. I have multiple cancers, multiple things. I have multiple things here, right? I use it for treatment as well, right? CA15-5, I'm not using it because it's primarily useful for metastatic breast cancers, not for the primary ones, right? So I can use it for prognosis. So I can tell exactly this is ERPR positive, a good prognosis. The patient might not have a disease recurrence in the next 10 years. Everything negative, bad prognosis. The patient will have metastasis, will die most commonly, right? I'm just giving you an example. Like that, I have prognostic features for every disease, right? So my goal is to diagnose, to research, and to prognose, right? That's the role of pathologist, and we know all the subdivisions of pathology, right? So my first part of my CBME curriculum is covered. The next part for me, this template which I already covered, is about cell adaptations. Let's take a cell. So we are coming, just now we are reaching the hardcore pathology. Till now it was just wishy-washy learning about pathology, fine? Okay. How many of you live in how or have gone to Jammu, Kashmir or colder parts of the country or the world? Have you traveled to colder parts of the country? Like Delhi is very, very cold, right? During winters. So if you've been to colder part of the country or during winter, can I say that you will put on a glove and a jacket? You will put on a glove and a jacket, right? Anshman, ER stands for estrogen receptor, PR stands for progesterone receptor, fine? Coming back to this, you'll put on a glove, you'll put on a jacket to tackle the cold. Let's say, same Delhi, you're in summer. Do you live with the glove and the jacket? Can you live? You can't live. It's extremely horribly hot, right? It's very, very hot. So, in other words, in response to any stress, my body adapts. You will adapt in response to any stress, right? You will adapt. I'll give you one more even a simple example. You just now gave your first year MBBS, right? Am I right in saying that the last 2 months you read for a longer time than for the 12 months of the year, you must have adaptation. So my body adapts to any stress. Can I say after exam you will not read the same 8 9 hours? You won't, which is reversible, right? So every cellular adaptation is reversible, right? Perfect. Narayan, I can feel you. I am from Chennai. Only summer. I don't have any other temperature, right? So any cell, when I have any amount of stress, it will adapt. It will obviously adapt. Like I said, that every adaptation will come back to normal, which means every adaptation is reversible. See, from now itself, remember, if I say every adaptation is reversible, there might be few exceptions. These exceptions are always MCQs. We'll read them when I go to the exception, right? So what can be this stress? This stress can be anything. The stress here is my etiology. We know the template, right? The stress here is my etiology. It could be an hormonal problem. It could be a UV light. UV rays can be a stress. It could be an infection. Infection could be a stress. It could be your mutations. That also could be a stress. It could be some immunological condition. That also could be a stress, right? All these are my etiologies. I can have various etiologies. I can have any infection, any UV rays, any mutation, or my autoimmune conditions. All of them can be stress. So whenever I have stress, a cell will adapt, and the cell will adapt and go back to normal. Let's say if the stress continues. In other words, right? In other words, let's say that you are not going to, you are in Delhi only, in extremes of the temperature, you don't have the glove, right, and not able to adapt, or the temperature keeps on becoming more and more and more and more cold. Is there a possibility you can have frostbite? Can there be permanent damage? It's not an adaptation, it will damage, right? Hello guys, am I better? If so, just give me a thumbs up or thumbs down. Yes or no? Okay, I hope it's at least a little bit better, and I hope it becomes better over the time. So we have done what a pathologist is going to do. Now I hope we will start with cell adaptations, and we know why a cell adaptation is required, and it's reversible and everything, right? Okay, great. So there are four different types of cell adaptations. We have hyperplasia, we have hypertrophy, we have metaplasia, and we have atrophy, right? So there are four different types of cell adaptation which is required for us to learn, and so that we can apply them in different clinical scenarios, right? Okay, I think I'm good to go. Right. So the first thing is hyperplasia. First you look at hyperplasia, then go to hypertrophy, then go to metaplasia, and then we'll go to atrophy, right? Okay, little bit uncomfortable. Fine. So first is hyperplasia. So guys, do comment. What do you think about hyperplasia? I'm sure you must have learned the first edition, first chapter of Lobens at least. Hyperplasia means increase in cell number or cell size, or decrease in cell number or cell size. When do you call something as hyperplastic? Is it increase in cell number or cell size? Hyperplasia simply means it's increase in the cell number. I'll tell you, Anshuman, just give me a second. I'll tell you what does it mean by adaptation is reversible. It's increase in cell number, right? I'll give you a little bit of easy way to remember. Most of the hyperplasias happens in hormonal dependent organ. Doesn't mean that it will not happen in other organs. Most of them, right? Most of the hyperplasia happens in hormonal dependent organ only. Okay. It can happen in other organs also, it can happen in other tissues also, but most of them what will be reading, most of them which will be applying in real life is going to be in hormonal dependent organ only, right? Perfect. So can I say a cell, when it's need to go undergo hyperplasia, it has to have the capacity to divide. If they don't have the capacity to divide, they cannot undergo hyperplasia, right? That's the basic rule for my hyperplasia. It needs to undergo the capacity to divide, right? Osama's right. Breast can undergo hyperplasia, uterus can undergo hyperplasia, and many other organs can also undergo hyperplasia, right? Now let's take normal physiological hyperplasia. In your Robbins, they must have categorized as physiological separately, pathological separately. I want you guys always to interlink physiology and pathology, because once you start interlinking physiology and pathology, it becomes much easier for us. Let's take whatever Osama said. Let's take uterus. Now, I want you guys to comment on whatever you read in your first year of your MBBS. What are the phases of menstrual cycle? There are three phases of menstrual cycle. Leave the menstrual phase, the other two phases. Tell me the other two phases of menstrual cycle. We'll take normal. We'll take a normal example of a physiology. We'll extrapolate into pathology, and then we'll understand everything, because it's always the interlinking and integration of the subject gives us definitely a far better understanding, right? Let's take a simple normal menstrual cycle, which I'm sure everyone will agree, which is a physiological process, right? In a menstrual cycle, in a normal physiological process, perfect. When I said that we have proliferative phase, perfect. They have proliferative phase. Can anyone comment more on the proliferative phase? Which hormone is responsible for the proliferative phase? The first phase for me is proliferative phase, right? Perfect. So for a proliferative phase of an endometrial cycle, like you guys commented, I need estrogen. Right? The perfect thing to say, yes, I require estrogen for a proliferative phase, right? I'll just extrapolate here. Can I say estrogen here is a growth factor? Am I right in calling that? Because estrogen proliferates or divides or grows my endometrium. That's why I term them as proliferative phase of endometrium, right? So my estrogen here is a growth factor. Again, I'm in the normal menstrual cycle. Once I have proliferative phase and estrogen, let's assume just for an example, I'm having ovulation. After ovulation, tell me what will happen to the levels of estrogen in a normal woman. I am not going to the pathology at all. In a normal woman, after ovulation, what will happen to estrogen? Estrogen levels will fall, right? Perfect. The estrogen levels will fall, then my progesterone levels elevate, then my proliferative phase becomes secretory phase, right? That's a normal thing here, right? So normally what happens is when ovulation happens, estrogen falls and automatically it goes to secretory phase, then it goes to my menstrual cycle, right? Perfect. So this is normal. Now let's take my etiopathogenesis. Just a random scenario. Let's say that I'm going to subdivide them as etiology, because I want you guys to tell me the etiology here. See, if you know normal, I believe that, and I am sure that you'll know abnormality also. Let's go into few etiology. Tell me conditions where estrogen levels will not fall. Okay, Anshuman is right. If my estrogen level doesn't fall, then can I call it pathological? It is right. We'll go with simple logics. Is there a possibility if a menstrual cycle there is no ovulation happening, the menstrual cycle is normal or abnormal? You can write normal for N, abnormal A for abnormal. If a ovulation is not happening in a menstrual cycle, can I call it abnormal? Obviously it's abnormal, right? Perfect. So if I'm having an ovulation, I call it abnormal. That's one of my etiology for my disease, what we're going to see soon. Second one, like Anshuman said, obesity. I'll come to obesity, I'll come to it very soon. Right? Next, have you heard about a disease called as PCOD, PCOS, where I'm going to have excess amount of estrogen? That's again excess. So it might not stop and it might not go into secretory phase, right? Perfect. Then, like what Anshuman said, have obesity. When a person is extremely obese, again, you must have read in your biochemistry, peripheral fat converts active estrogen, right? It converts estrogen into a much more active form. Again, that's an abnormal thing for me, right? So that also is a concern. Last but not the least, can anyone comment? Again, I'm going back to physiology. See, if your first year is good, entire MBBS is good. In your normal ovary, which cell secretes estrogen? Just I want to comment on the answer. I'll give you options also. You have your theca cell, you have your granulosa cell, you have your ovarian stromal cell. Which cell secretes estrogen in a normal ovary? It's a very simple question. Answer is simple. It's a granulosa cell, right? So if it's a granulosa cell secretes estrogen normally, when I have a tumor, let's call it a granulosa cell tumor. Okay? Granulosa cell tumor, right? Theca cells don't secrete estrogen. Granulosa cells secrete estrogen, right? Theca luteum. Theca is equal to pregnancy, right? Corpus luteum. All those theca cells, luteal cells will be involved in your progesterone, not estrogen, right? Perfect. So my granulosa cell tumor, I'm going to have more estrogen secretion because the normal function of granulosa cell is to secrete estrogen. Tumor, definitely more estrogen, right? So just we'll come back to the normal. See, this is my etiology because these are all abnormal. Anovulation is abnormal, PCOD is abnormal, obesity is abnormal, granulosa cell tumor is abnormal, right? In all these conditions, my estrogen levels will not fall. In other words, can I say the stress will be persistent, right? I'll have persistent stress, okay? When there's persistent stress, I just want you to comment whether the endometrium will become hyperplastic or not. Yes or no, just Y or N. With persistent stress of estrogen, due to these conditions, I'm going to have more endometrium becoming hyperplasia, and I'm going to call that in simple terms. We won't make life difficult at all. Medicine is very, very simple. Human beings is what makes them difficult, right? I'm going to call them endometrial hyperplasia. Like I said, whatever you're going to learn from today, the only goal is I have to take etiology, pathogenesis, clinical feature, diagnosis, management. That's all, right? So now here, I know normal menstrual cycle. I have created etiologies. Can I call this condition, this as the pathogenesis? Obviously, this is my pathogenesis, right? So obviously, is the pathogenesis, right? Just a second. The entire thing of endometrial hyperplasia is your pathogenesis. Entire thing is your pathogenesis, right? So now I know my pathogenesis, I know my etiology. Can you predict the clinical feature? You're very young in your medical career, but still you can predict clinical picture. So no, just give me a second, I'll tell you. Normal, let's assume a normal endometrium, let's assume for an example, is 4 millimeter in thickness. Okay, a normal endometrium is 4 millimeter thickness. In endometrial hyperplasia, it becomes, let's say, 10 millimeter. I'm just giving you a random example. This is not the right numbers. Normally 4 millimeter, the menstrual phase is going to have, let's say, 50 ml of bleeding. So what will 10 millimeter have? What will be the symptom? Can I say any patient with endometrial hyperplasia will have or should have more bleeding during menstrual cycle? I'm not using any pathological terms, simple terminologies, right? So my pathogenesis is this, my pathology is this, my clinical features is going to be increased bleeding, right? What's a technical term for increased bleeding? Perfect, menorrhagia. I'm talking about the history. History is very, very simple. The patient's presence with menorrhagia, that's all. So I know my clinical feature, I know my etiology, I know my pathogenesis. The next only thing for me is diagnosis, right? Sana, uterine fibroid will not cause endometrial hyperplasia generally. And Sonu, PCOS means there's a disease called as polycystic ovarian syndrome or ovarian disease, right? You will learn about polycystic ovarian syndrome very soon. That's your PCOS or PCOD, fine? Okay. Sana, fibroid will not cause this. Fibroid is totally different thing. We'll learn about fibroid very soon, right? So clinically, I'm going to have menorrhagia. Your goal and my goal going forward is only one. I have to diagnose patients. If I can diagnose patients, you will definitely treat patients. I'll go back to my etiology. See, I'm going very slow for the only reason I want you to be very strong in this. Obesity, the way to diagnose or the clue will be BMI. If it's an MCQ, it'll be written BMI of 35-40, definitely obese individual. In a real life, you know it's obesity. The person will be obese, right? Granulosa cell tumor. The history will give you an abdomen mass. Or if you have to be very specific, I will call them an adnexal mass because in uterine, adnexa and anatomy is just next to it, right? Uterine, adnexa is where I see the ovary. Either adnexal mass or an abdomen mass, I'm going to think of a tumor. That's a history. So PCOD, PCOS, when we go to your gynecology, you will read them. It will have, in addition to menorrhagia, something called as hirsutism. I'm sure some of you at least will know what a hirsutism means. Excess growth of hair in women, little bit of beard, little bit of mustache. That's hirsutism, right? So women like a 40, 25, 30-year old women with more amount of hair growth, it's again due to hormonal imbalance. With menorrhagia, I think of PCOD. Next, anovulation. That's a beauty part. Tell me when you will have difficulty, when you are doing something at the first time or you're doing it for the 10th, 20th time. When will you find anything difficult? First time or multiple times? Always the first time, right? When I do something the first time, I'll find it difficult. So can I say my ovary is starting to ovulate during puberty? Is there a possibility of anovulation? Just now it's starting to ovulate. It's just now it's understanding about the menstrual cycle and everything. Is there a possibility of menstruation? There is, right? So anovulation is very, very common in puberty. We have a condition called as in puberty menorrhagia, right? So anovulation is very, very common in puberty. So now I know my etiologies. I have clues here. So what will be given in MCQs is, it's very simple. 14-year-old kid or 15-year-old kid having menorrhagia. I call the reason as puberty menorrhagia. It's the first time the ovary is trying. You are reading for the first time. If you're not doing something good, doesn't mean that you're a bad doctor. You're an amazing doctor anyway. I am there to support you. That's all. Same way, my ovary is and the uterus is trying to learn everything. So I have to support the ovary and uterus for some time. That's all. If I can support the ovary and uterus for some time, can I say the puberty menorrhagia can automatically become normal? Like you guys are going to become amazing doctors, puberty menorrhagia also will become normal. Now you are going to tell me the treatment. Listen, understand, and answer carefully. It's completely fine if you're wrong, but I want you guys to answer. My ovulation is not happening properly. It's struggling at the start. So what I'm going to do is I'm going to make sure the ovulation mimics like my normal body. Normally it will be estrogen. After ovulation, who comes? Progesterone. So the way or the easiest way of treatment of anovulation or puberty menorrhagia is give OC pills. Right? I have lots of etiology here. We know the clinical feature. The way going forward for treatment is if it is due to puberty, it's struggling to learn. So let me help for some time. Give hormonal pills. You will read about lots of hormonal pills in future. I'm sure you must have heard about oral contraceptive pills, right? I'm just going to give hormonal pills. Wait for a few months. It'll automatically learn. If it's PCOD, PCOS, PCOD, PCOS is actually a way of metabolic syndrome. One of the easiest treatment is metformin. So you have to give estrogen or you have to give progesterone. The problem is actually more estrogen, right? Estrogen or progesterone? Progesterone should be given, right? I can give metformin. The third one, if it's a granulosa cell tumor, I have to remove the tumor. Surgically remove the tumor, automatically it takes care of it. A tumor is a more important problem than menorrhagia, right? Remove the tumor. What do you think is the treatment for obesity? What's the treatment for obesity? Quite a few of us must have gym subscriptions, right? You'll never go to the gyms, right? You'll never ever go to the gym. Obesity is a silent pandemic. Can I say I gave you 4 etiologies? Of that, puberty can be taken care of, PCOS can be taken care of, to some extent granulosa cell tumor can also be taken care of. Am I right in saying that the obesity here is something which will never go off? It'll always be there with them. My pant says keep on increasing, it'll never decrease unless and until I'm a fitness freak. Right? Exercise is a goal, but everyone here knows that we are not going to do exercise, right? It's very, very difficult. In other words, I'm going up. In other words, can I say obesity is a place where I will not be able to remove the stress of hyperestrogenism. Osama, Dr. Ankit will tell you when we come to anti-hypoglycemic drugs, fine? In other words, is the statement right? Obesity is where the stress of hyperestrogenism can never be removed. It can never be removed. In other words, can I say there I'll have more and more and more hyperplasia of endometrium? Yes, I will have more and more hyperplasia of endometrium, right? Obesity is a place that where my stress is going to be extremely persistent. It's going to persist. When I have a persistent stress, okay, when I have an extremely persistent stress, I'm not able to remove. Here, my endometrium will have tremendous amount of hyperplasia. It will keep on dividing. It will keep on having hyperplasia, right? If there's an extreme amounts of hyperplasia, is there a tiny possibility, a very small possibility at least, of it becoming carcinoma? Is there a possibility that this hyperplasia can at least slightly become carcinomatous? It can, right? It can become carcinoma. Now, I want you to apply the terms what we told. Listen carefully and answer. So now, can I call obesity as a risk factor for carcinoma of endometrium, or will I call it etiology of carcinoma of endometrium? I just want you to understand between these two and answer. Is obesity a risk factor of carcinoma of endometrium or etiology of endometrial carcinoma? Obesity is in, we know both the differences, right? Is it the cause? Is the risk factor? Here, I want you to use the term risk factor. I'll tell you why I changed the terminology from cause to a risk factor. Because if it's a cause, every obese individual should have endometrial cancer. It's never like that. It's always a risk factor. If a person is obese, if like let's take 100 people are obese, there might be 2 or 3 who can have endometrial carcinoma. Not everyone, right? Perfect. I'm going to use the word risk factor because not every obese individual will have carcinoma of endometrium or carcinoma of breast. That's the difference between etiology and a risk factor. I hope it is clear, right? The cause and the risk factor. Perfect. So I know now everything, a little bit about the endometrial problems, the hyperplasia. We just took one. I want you to apply the same concepts in multiple places. See, there are lots of examples for physiological hyperplasia. This is for you to fill up your exam sheets. Right? The first one, what we saw is for us to learn, to understand, to diagnose, to treat patients, and next thing is for your exam sheets. Which part again, Anshman? The question was simple, whether it's a cause or a risk factor. It's a risk factor, fine. So for few more examples of physiological hyperplasia, the first thing is liver. The liver has an best capacity to undergo hyperplasia, right? Liver, even if you cut half of the liver, the rest half grows. Okay, the rest half of the liver grows because liver has an extremely superb way of undergoing hyperplasia. I'll tell you why it has that capacity for undergoing hyperplasia. In liver, we have a growth factor called as scatter factor. In the first chapter of Robbins, these informations will be given. We have something called as scatter factor, right? Okay. So when I have something called scatter factor, let's say here is my growth factor. A normal growth factor, which is not a scatter factor, it will just divide into two. Vaibhav, yes, if there is no persistent problem, the endometrial hyperplasia is reversible. I treat PCOD, it comes back to normal, right? Otherwise, it doesn't come back to normal, right? Normally, let's say it divides into two. If there's a scatter factor involvement, the factor scatters. So what happens is it divides into more. Since a scatter factor there, that's the reason my liver undergoes or has a tremendous capacity of hyperplasia, right? That's a physiological hyperplasia. Next. Tell me, tell me any one more organ which will respond to your hormone of estrogen. Apart from endometrium, can anyone tell me any one more, any organ which responds to your hormone? Can I say breast? It is, right? So breast also responds to estrogen. Breast parenchyma will respond to estrogen for sure, especially during puberty. Puberty is where the breast starts developing again because of the hormone only, right? Breast parenchyma develops. It does. It divides. I'll have hyperplasia. At the same time, can I say uterus? When the mother is pregnant, am I right in saying that uterus will definitely become big? We all were born at 3 or 2 or 3 kg, right? The uterus has to hold 3 kg baby for 9 months. It will become big. Uterus also will undergo hyperplasia. Okay, it also will undergo hyperplasia. But one unique thing which makes them, for MCQ point of view, is these both organs will have both hyperplasia and hypertrophy. That's one unique thing. Please don't go into the fight of which is more, which is less. That is not required for me. It has both hyperplasia and hypertrophy. Fine. Okay. So that those are few examples of hyperplasia. One more hyperplasia, then we'll go to the next part. This is actually in Robbins put in under physiological, but it's not exactly physiological. Maybe I will be much more comfortable to put pathological, but I'll give you that example, right? Let's take bone marrow. In a patient with a bone marrow, like every one of us has bone marrow, right? The function of bone marrow is to produce RBC, WBC, and platelets. That's all. Right? A very simple function of producing RBC, WBC, platelets. Let's assume a patient has the bleeding. The patient fell down and there's lots of blood loss. What will bone marrow do? I'll come to it, Osama. Just give me a second. The person has like 500 ml of blood loss post a trauma, fell down accident, has a blood loss. What will bone marrow do? Can I say bone marrow should compensate the blood loss and grow more? Yes, right. Bone marrow will also undergo hyperplasia in response to any damage. Whenever there's a blood loss, bone marrow undergoes hyperplasia. Not just blood loss. I can say that we have few diseases called as hemolytic anemias. I'm sure you must have heard about sickle cell anemia and thalassemia. Yes. When a person has sickle cell anemia or a thalassemia, my bone marrow is definitely going to undergo hyperplasia, producing more and more blood. Because as blood lost, it's going to produce more. It's very simple. Again, it's not only about blood. Can I also say when a person has infarction, my WBC should be more? Will the bone marrow produce more? It will. When the patient has platelet loss, should the bone marrow produce more? It will. Be it RBC, WBC, platelets, whenever anything is lost, my bone marrow compensates and produces hyperplasia, right? Right, so those are two different things about bone marrow. Fine. Okay, now like I said, these are all examples for you to fill up the page, because no one is going to worry about uterine hyperplasia and pregnancy, because it will never cause a problem for me. Puberty breast hyperplasia is normal, liver hyperplasia is normal. Anytime liver dies, it reproduces automatically. I don't have a practical application for these, so I might not require to remember more, but this have very important practical application. I have to read them. See here, I told you about a template, right? Etiology, pathogenesis, clinical features, diagnosis, management. We have covered everything except one place. How do I look them under microscopy? That's the diagnostic part. That's my role. When I take a biopsy of the endometrium, how does it look? It's very simple, right? Most of the students feel that in pathology, the difficult part is microscopy. The easiest part is microscopy. The difficult part is memorizing all the facts. You are amazing in memory. The difficult part is not the microscopy, right? I'll just give you two examples here, right? This one, two. I'll come to it, Anshuman. I'll come to it. I think I wanted to answer one more question of Osama as well. I'll reply to that also soon. There are two slides here. Can I call this a gland? Is that a gland? Obviously, right? You must have learned about glands in your histology of first year. That's a gland. Of these two, just tell me which of these two images has more glands, one or two. Which has more glands? It's a very simple question. Obviously, 2 has more glands, right? When 2 has more glands, can I call the second image to be, if this is from endometrium, can I call the second image to be hyperplastic endometrium? That's all. So this is an normal endometrium. It's beautiful, right? This is my endometrial hyperplasia. And you guys need not worry about a microscopy. Leave microscopy to me. We will use simple logics, what we already know, to apply and diagnose. We know about endometrial hyperplasia and we know about normal, right? We know everything regarding hyperplasia, whatever is required for us, fine? Okay, there are two questions. One is, Osama, parenchyma and intracellular space are not exactly the same. Maybe I can use it similar. Let's take this example only. These are my glands of endometrium. This entire thing in endometrium, the stroma is what I call it as parenchyma. Even in stroma, I have cells. I have two cells in stroma. The space between them is intracellular space, right? So parenchyma is the stroma of any organ. Breast also has glands. That's what secretes milk. The fatty parenchyma of the breast is a stroma, right? So parenchyma is different, intracellular space is different, right? Next, Anshuman, coming to question, yes, altitude sickness also there is more RBC production. The only thing there is etiology is different. That's all. It's a physiological etiology. Whenever you go to a higher altitude, oxygen becomes less, erythropoietin becomes more. My bone marrow proliferates to produce compensatory RBC rise. That also will have bone marrow hyperplasia. You are right in calling that. Fine. Perfect. So now we know everything about hyperplasia. We know it can cause a complication of cancer and it can be reversible. Sometimes because when the stress is more, it may result in complications as well. Fine. Perfect. Now let's go to hypertrophy. So hypertrophy, I not give you much example. Hypertrophy is increase in the size of the cell. Okay, it's increase in cell size. I'm sure everyone here knows about the physiological hypertrophy example. What's the example? No one will ever forget that example, right? Physiological hypertrophy, the example is perfect. It's nothing but your body building, skeletal muscle building, right? So muscle building is one of the examples for physiological hypertrophy. Just give me a second. Okay. So when I say muscle building increases physiological the muscle size, I have one more striated muscle in my body, which is my cardiac muscle. Am I also right in saying that when I lift a weight, my biceps becomes bigger? When my heart functions more, will the heart also become bigger? Because that also is a physiological, that also is a striated muscle. If biceps becomes bigger, and if that is true, my heart also should become bigger, right? That also should be true, fine. In other words, most of the hypertrophy in hyperplasia, I gave you a thing. Most of the hormonally responsive organs will undergo hyperplasia. In hypertrophy, it's mechanical. It's a mechanical stimulus in most of the conditions. Here it's not hormonal, here is not growth factor. More weight, this became bigger. More work of the heart will become bigger, that's all. Right? Physiological hypertrophy, I'm not concerned about it because if you have a good body, it's good for you, that's all. But my pathological hypertrophy, the other thing which I'm very much worried about, right? So physiological, I'm just writing it for namesake. It's your skeletal muscle which undergoes physiological hypertrophy. For pathological hypertrophy, the other striated muscle, skeletal is also striated, the other striated muscle is your cardiac muscle. Okay, cardiac muscle also has a problem. Athletes have hypertrophic heart, that's true, because for athletes they work more, so automatically my requirement is more, my heart has a compensation. That I am not having a problem, because am I right in saying that in athletes the heart rate also will be low? You must have read that in physiology, right? Heart rate also will be low in athletes, right? Because my heart is bigger, pumps more blood. I'm just maintaining the low heart rate so that everything is normal, right? There will be compensation for sure. What I'm worried about is the pathological conditions. Athlete is completely fine. They are more fit than most of us, right? Let's take your cardiac muscle. The cardiac chamber. I have to take my left ventricle. Okay, I'm just giving you an example of left ventricle, but this is applicable to every ventricle. Since you're just fresh from your MBBS, first year of MBBS, you're going to help me more in this. I have two forces against which my heart pumps. I'm sure you must have heard these terms. These are important questions in physiology, right? Preload and afterload, right? Preload and afterload. You must have definitely heard about that. What determines preload of a right ventricle? I'm not asking about the left ventricle. Tell me what determines the preload of a right ventricle. For right ventricle, the preload is venous return, right? Am I right in calling that as venous return? Yes. My venous return is the preload for right ventricle. What is the preload for left ventricle? Because left ventricle venous return doesn't come inside, right? What is the preload for left ventricle? For left ventricle, my preload is end diastolic volume. I'm using this abbreviation. You have to know this abbreviation. You must have learned also. It's end diastolic volume, right? The end diastolic volume of the left ventricle is the preload for the left ventricle. What is the afterload for the left ventricle? We'll leave right ventricle now. We'll go to left ventricle. The afterload for left ventricle is your total peripheral resistance. Again, this abbreviation is also known. Since you know EDV, I'm not writing the expansion. It's total peripheral resistance, right? That's the afterload against which my heart is going to pump. The left ventricle is going to pump, right? Perfect. Now let's say in a patient whose total peripheral resistance is high, it's a vessel, the resistance of the vessel is high. So in other words, can I say this patient is suffering from hypertension? Possible, right? Perfect. So whenever there's an increase in total peripheral resistance, I'm going to call them hypertensives. It's blood pressure. Blood pressure is increased, right? Because I'm sure you know the formula of the BP, cardiac output into total peripheral resistance, right? So more total peripheral resistance in hypertension. So in other words, can I say a person who is hypertensive, that person's heart should work more than all of our heart? Yes, Sahil, you're right. For the right ventricle, it's different. Yes, it's right. Fine. So when my hypertension is there, my heart should definitely function more. Let's come to this part. I'm erasing end diastolic volume for now because you guys know that, right? So now let's say my heart is like this. Let's assume this is my right ventricle and this is my left ventricle, right? And you have the aorta. Okay? So aorta, between the left ventricle and the aorta, I have my aortic valve. Whenever the heart pumps, the valve opens. After that, the valve closes. Let's assume if the valve is not closing properly, it pumped, it didn't close completely, there's a gap. Is there a possibility blood can drop back into the left ventricle? Is there a possibility? If my valve of aorta, if aortic valve is having an incomplete closure, is there a possibility the blood can drop down into the left ventricle? It can, right? Perfect. If that is true, I'm going to name this condition. I call this condition aortic regurgitation. It's coming back, right? You will learn aortic regurgitation when you come to your clinical postings. It's very common thing. It's aortic regurgitation. In aortic regurgitation, am I right in saying that the heart of an aortic regurgitation patient should work more than you or me? It's true, right? Perfect. So I know an increase in my preload as well as I have an increase in the afterload, and you guys accepted for in both the condition my heart should pump more. In other words, I'm going to rephrase them. One, can I call this as an pressure overload? I'm having more problem in the pressure as your pressure overload. And here it's not the pressure, it's the volume overload. I'm just going to rephrase them, that's all. One is due to the total peripheral resistance, which is my pressure. One is due to the volume, end diastolic volume, volume overload. Now, heart behaves differently to pressure and volume. Not just heart. Everything in my world behaves differently to pressure and volume. I always used to say that don't try to read medicine from textbooks. Read medicine from your real life. Then you can easily compare to my textbooks. Right? You can easily compare to the textbooks, right? So here, let's say that use a simple balloon. I'm sure everyone here must have played with the balloon, right? If you're not played with the balloon, please go and play back with the balloon. Right? Life is more important than medicine. So when you blow air into a balloon, that's pressure. The balloon becomes oval or round, depending on the size. At the same time, when you fill water into a balloon, the balloon doesn't become round, right? When you fill water, water always goes to the most dependent part. So balloon, am I right in saying that when I fill water, a balloon becomes like this? Is that statement right? Because volume always goes to the most dependent part. On the other hand, when it's a pressure, it becomes like this, right? Oval or round, whatever shape it is. In other words, can I say the pressure exerted is always uniform everywhere? You're sitting in the room, right? Can I say the corner also has the same atmospheric pressure compared to the center of the room? It's always same. It will never alter. So in other words, the pressure will be uniformly exerted. In other words, my volume will be always most dependent part. So now tell me, if my pressure is more, like let's say, okay, if the pressure is more here, right? Can I say this part of the heart is the only thing which will definitely hypertrophy compared to the top part? Yes, obviously, right? So when my pressure is more, the hypertrophy also becomes more. In other words, this part is where I'm going to have more and more hypertrophy. The heart undergoes hypertrophy here. But in pressure, sorry, that was in volume. In pressure, it undergoes hypertrophy throughout, because throughout the heart I'm having equal pressure, right? So that's how my heart changes. In one place, only one part, the dependent part, undergoes hypertrophy. In this plate, everywhere undergoes hypertrophy, right? Perfect, simple. Don't ever forget anything what you read. Laplace law, what you read in physics in your 10th standard, also will help me to learn medicine. It's same, that's all. Now I want to ask you a question. This hypertrophy, uh, sorry, this hypertrophy here is a hypertrophy of the apex or base of the heart. This hypertrophy, I have to call it apical hypertrophy or base hypertrophy. This is the hypertrophy towards the apex. If you have commented or wanted to comment base, hold it. That's where you make mistakes because you wanted to answer in a hurry. That's a problem. It's not always answering first, it's always answering correct. In heart, apex of the heart is below, base of the heart is above. That's what you must have read in anatomy, right? Apex of the heart is below, base is always above, right? It's an apical hypertrophy of heart. It's a simple apical hypertrophy of heart. In other words, I will call them an eccentric cardiac hypertrophy. I have to put a technical term, right? If I simply call it apical hypertrophy, every one of you will read and become great. So they will put a technical terminology there, eccentric cardiac hypertrophy, right? Fine. So here I use the term concentric cardiac hypertrophy. It's eccentric cardiac hypertrophy and concentric cardiac hypertrophy. Fine. Simple. Perfect. Ankita, you need not be sorry at all. If you made a mistake here, it's completely fine. You make a mistake, I'm writing and giving you, you are the only person who will remember this mistake. Other people who answered correctly might ignore it, but you'll never ever forget it, right? It's completely fine. Please never be sorry for any mistake what you do. Right? Okay. So I'm eccentric and I have concentric cardiac hypertrophy. So this is how my heart behaves to my pressure. My question is, why did the heart work so much? It's having hypertrophy. When there is hypertrophy forever, again and again and again, it's due. Let's take this person due to hypertension. If a person is having hypertension, let's say for the next 10 years, 15 years, can I say the hypertrophy will become bigger and bigger and bigger? Will it narrow down the orifice, the your chamber? Will it reduce the cardiac output? It will reduce the cardiac output, right? If it reduces the cardiac output, will the patient have cardiac failure? Patient will have. That's why hypertensives on a long run, if it is not controlled properly, might lead to congestive cardiac failure, where my cardiac output will become less because of this problem. So is there a need for me to stop this? Should I stop it or let it continue? Because we know that it's an hypertrophy, it's an adaptation, it'll be reversible. I should stop that, right? The best way to stop this hypertrophy, both of them, is take care of the etiology. Give antihypertensives so that you control this blood pressure, make sure it's always normal so that this hypertrophy over the period of time will come back to normal because it's an adaptation, it is reversible. But if you're not able to control the blood pressure, it will automatically become abnormal. It will result in cardiac failure, right? Okay. So the ultimate goal here, the goal of this hypertrophy or goal of any cell adaptation is to make sure to maintain cardiac output. It's becoming more thicker so that it can definitely push the required blood outside, be it your aortic regurgitation or be it your concentric hypertrophy. It has to make sure everything goes properly, right? So which means I have a mechanism here. So the mechanism is what we're going to learn, right? Aneurysm will take it sometime else, Sana. Might not always result in aneurysm, but yes, cardiac failure will definitely happen, right? So we have to go into the molecular methods. We know that superficially the heart will become big, but how does it become big? That we have to learn more, right? So it can be either the mechanical stretch. The mechanical stretch is the stimulus here, or it can be few agonists, right? Any of the hormonal angiotensin, all these receptor problems can also be there, right? So whatever be the problem, in any case of pathological hypertrophy, it's always via G protein coupled receptors. Okay, G protein coupled receptor pathway will be there. I'll tell you why and what why should we read this very soon, right? It has few transcription factors in the pathway called as, at least remember this transcription factor called as GATA4. And there are a few more transcription factors which is mentioned in Robbins. If you forget them also, it's okay for me, but please don't forget this factor GATA4. I'll tell you why. Because of this GATA4 transcription factor being released, these are my transcription factors. I'm using the same step what you must have learned in your physiology for your receptors, right? Receptor, I have a stimulus, I have a receptor, I have transcription factor, right? Then this transcription factor will result in your few changes, few gene changes. I'll tell you what gene changes it is. Second, it will cause more synthesis of proteins. You'll have more proteins there. When there is more protein, what will happen to the size of the cell? Obviously, it will become hypertrophy, right? It's all about hypertrophy. It becomes more. Okay? It's not just that, it produces more growth factors. It produces more growth factors. This growth factor, what they will do is, again, this is a vicious cycle for me. I hope I'm not hiding that, right? It produces more growth factor. This growth factor will again sit on the receptor. The receptor, let's say angiotensin receptor. Okay, it goes and causes again G protein couple, GATA4 and this. So here there are two things for me. Now it's a hypertrophy which is going on again and again and again. You have to block this. If you remember antihypertensive drugs, we have a group of drugs called as ARBs. Dr. Ankit will definitely talk about that. Angiotensin receptor blocker. It's a very superb drug because it doesn't only take care of hypertension, it blocks this entire process because it blocks the cardiac hypertrophy secondary to hypertension. Superb drug, right? The more protein involvement is what is going to make in microscopy. I'll show you in microscopy how it looks. The gene change is very important. Right? I'll give you ask you a question. You're going to answer me. From that, we're going to take it forward, right? So tell me, which in a kid's heart, a kid heart is more effective in pumping the blood, or an adult's heart is more effective in pumping the blood? Which heart is more effective in pumping the blood, kid or adult? It's definitely the kid, right? Because kids beat very fast, so they're more effective. They can work in a place when the oxygen levels is less, because kids, the when I say kids, it's the embryonic one, the fetal or the embryonic one, right? The fetal hearts gets the oxygen from the mother's blood, not from the air like us. So they can work beautifully even in less oxygen supply. So what my genes alter is, this genetic change will nothing but it will replace a form of myosin, right? In all of us, right? All of us will have alpha myosin heavy chain, which will be replaced by beta myosin heavy chain, because beta myosin can work in very less oxygen also, right? The genetic change, maybe I'll write it down. The genetic change, what will happen is the alpha myosin heavy chain, which is seen in adults, will be replaced by beta myosin heavy chain, which is seen in infants, fetus. It's a fetal isoform. The reason being, fetus has less oxygen supply and they can work beautifully with less oxygen supply. It's an hypertrophied heart, very thick heart, but the blood supply doesn't change. Same blood supply. They have to work more efficiently. One for more efficient work, one for more contractile nature, one for to make it more and more vicious cycle, right? So this is what happens in the hypertrophy of the heart. Like I said, now why should I know this? The reason to know this is very, very simple. If I can not stop ARBs, let's say the person's hypertension is not responding to ARB, can I say I can produce a blocker here? If I produce a blocker which blocks GATA4, will the entire hypertrophy stop? It will, right? That's my future. I have GATA4 blockers in study, in research, to make sure that cardiac hypertrophy reverses even in uncontrolled hypertensive. There are lots of uncontrolled hypertensives. They will end up in cardiac failure. So I'm researching, by knowing the pathogenesis, I am researching deep so that I can solve the queries. So these might not be important for MCQ now. Maybe when 10 years down the road, when you start practicing, I might have a GATA4 blocker, which you give to reverse cardiac hypertrophy in hypertensive patients, right? So that's the use of learning all these, right? Perfect. So now I know the problem. Now I know exactly what change happens in hypertrophy, right? So we know a little bit about cardiac hypertrophy, and we definitely know a little bit about your skeletal muscle hypertrophy. Now my only concern is the image, the microscopy. Microscopy is the most easiest thing. Like I said, I have a thumb rule for microscopy. Remember this thumb rule always. For any biopsy you see from now on, be it in your MCQ or be it in your college, the easiest thumb rule is, if it's blue in color, it's DNA or RNA. Anything with nucleic acid will be blue in color. If it's pink in color, rest everything in the cell is pink in color. Apart from DNA, RNA, rest anything in my cell is pink in color. And if it's clear, that's colorless or white, because the background is white, right? If it's something is white or colorless, it is fat. Remember this thumb rule always. Even if you're stuck somewhere, you will be able to diagnose it, right? That's some things are required. Like I don't know anything. With these three things, I may look at the MCQ and solve the options, right? Now, tell me, what do you think will be the normal protein's color in a biopsy? I told you the thumb rule, so you're going to tell me the color of protein in a biopsy. Normal protein's color in a biopsy. I'm sure you know the answer. Color of protein? Pink, blue, or clear? Simple ones. Perfect. The answer is pink, right? Is it stuck or is it normal? I hope it's normal, right? It's a very simple thing. It's pink in color, right? So normal protein in a microscopy will be pink in color. So if it's an extra protein that's seen in hypertrophy, cardiac hypertrophy has more protein, right? More pink or less pink? Simple. In case of hypertrophy, where I'm going to have more protein production, I'm going to have definitely more pink in color. That's all. It's about pink and blue. You can Excel microscopy diagnosis just with few known facts. That's all, right? Now I'm going to show you an image. You're going to tell me whether it's which is hypertrophy, which is normal, right? One, two. Tell me which is hypertrophy. Or in other words, which is more pink in color. More pink color, that's all. That's very simple to understand, right? Obviously, the number two is hypertrophic cardiac muscle. This is an image from Robbins only. This is not actually the cardiac muscle image. It's for the uterus, with whatever microscopy will be given in the any muscle here. Right? It's hypertrophied muscle. So any hypertrophied muscle, be it skeletal muscle, be it cardiac muscle, or uterine muscle in pregnancy, every muscle when it's hypertrophied, it will become pink in color. The first is a normal muscle fiber. Okay, as a normal muscle fiber, there's a hypertrophied muscle fiber. Very, very simple. Because normal has less pink color. I'm sure you guys will accept that this is definitely more pink compared to that one, right? Okay, that's how I diagnose the microscopy, which is normal, which is abnormal. You only diagnose the hyperplasia, endometrial hyperplasia microscopy, and you are only telling the microscopy of the muscle as well, fine? Okay, that's my second adaptation. We know about hyperplasia, we know about hypertrophy. The third one is metaplasia. It's very, very simple. Yeah, if you are all fresh from your first year, right? Do you have your medical dictionary still? When you joined your first year of MBBS, they must have given you medical dictionary. You must have thrown in the dustbin along with Cunningham. Both of them you won't read after a week, right? If you still have the medical dictionary, read every day 10 words, because medical dictionary will convert whatever is there in the textbook to English, which we can understand to some extent. That means I need not memorize. When you memorize something, it's difficult to remember for a longer term. You understand medicine. Once you start understanding medicine, the love for medicine always increases exponentially. It's just about understanding. It's meta. Meta means change, right? You know that meta means change right from your school days. A lizard losing its tail, metamorphosis, change in morphology, right? Meta means change. So metaplasia means it does just means change in growth. Don't forget anything what you read from the day you started read, right? It's change in growth. That's all. That's enough for me to know everything about metaplasia. Obviously, I need to have a stress. Only due to a stress, there'll be a change in growth, right? Now, the exact definition of metaplasia, if you ask in a viva or in an exam in an university exam, you're right? So the definition of metaplasia is one adult mature tissue. Mostly it's epithelial metaplasia, one adult mature epithelium, or I can call it a mature tissue. One adult mature epithelium changes to another adult mature epithelium. Okay? It should be adult and it should be mature. Right? Okay, one adult mature epithelium becomes another adult mature epithelium. That's what metaplasia is about, right? What is the first metaplasia which comes to your mind? If you talk about metaplasia, you'll definitely remember one person. An example is Barrett's esophagus, right? I'm sure everyone remembers Barrett's esophagus only, right? So a mechanism of metaplasia is also important. The one epithelium is becoming another epithelium, which means a squamous epithelium becoming columnar epithelium. So which means the stem cell should change. Only when the stem cell changes, one epithelium becomes another epithelium, right? So here the mechanism of metaplasia is there's something called as reprogramming of stem cells. You could reprogram stem cells. Okay, that's what happens in the metaplasia. It's just going to be reprogramming of stem cells. This can come in a Viva question. Do remember them, fine? Obviously, as metaplasia, we remember Barrett's esophagus, right? Because Barrett's is something which is there stuck in our head. We learn with an example, but that is not a common example. Common example is something else. I'll tell you, and you guys will accept that that's not a common example for sure. But obviously, we're going to learn metaplasia with your Barrett's esophagus. Your Barrett's esophagus must have been extremely exciting when you start learning abnormality, right? The most common, the etiology for Barrett's esophagus is GRD. Now, the risk factor is GRD, right? It's GRD and Barrett's. I'm sure you guys know what is GRD. Gastroesophageal reflux disease. Simple thing. What is the normal lining of esophagus? We have to know normal to learn abnormality. The normal lining of esophagus. If you know normal, I'll definitely make sure you understand abnormality. If you don't know normal, we'll learn normal first, then we'll understand abnormality. The normal lining of esophagus is, I'll come to that Sahel, is squamous epithelium. Right? Stratified squamous or squamous epithelium. We'll write stratified squamous only because I need that also. It's a stratified squamous epithelium, right? Can I say my skin is also stratified? My skin is also stratified squamous epithelium, right? Gastroesophageal reflux disease, which means stomach content is coming to my esophagus. In other words, the acid in the stomach is coming to my esophagus. pH of stomach acid is 1 to 2, which is equivalent to the pH of your sulfuric acid. If you drop sulfuric acid on your skin, what will happen? Your skin will burn. It will burn, right? So can I say, this is my normal esophagus. When a person has GERD, the acid reflux goes to my esophagus. That will result in the burning of esophagus. It will definitely be damaged, right? It obviously will be damaged. It will be burnt, it will char, right? In other words, this GERD is a stress for me. The acid is a stress for me. My body will always try to counteract stress. It's a mechanism, it's an adaptation. It will burn, so I have to make sure I have to counteract that. It's an acid excess, right? It's an acid. Acid is a problem here. How do you neutralize an acid? Going back to chemistry, I'm going to take all your knowledge of your school days, use it for medicine. All your knowledge of your living normal life and use it for medicine. Perfect. The acid will always be neutralized by base. Base is nothing but bicarbonate. Which secretion is rich in bicarbonate? First year of MBBS, you must have read about mucus secretion. Mucin, right? Bicarbonate rich secretion is mucin. Entire GIT mucin is rich in bicarbonate, right? So I produce a base so that I can neutralize my acid, so that in spite of GRD, I can save my esophagus, right? Antacid is my treatment. I'm going to use what my body is going to do is what we're going to learn, right? So here, the mucin needs to be produced. Going back to histology in your first year, there's one cell which secretes mucin. We call them. Have you heard about this cell? Obviously, you must have heard about the same goblet cell. That secretes mucin, right? Apart from that, goblet cells is a cell seen in columnar epithelium, right? So I call them an columnar metaplasia. It's changed. From squamous epithelium, it has changed to an columnar epithelium. I use term columnar metaplasia. In columnar epithelium, only one cell secretes mucin, which is goblet cell. So I can also call them an goblet cell metaplasia. Am I right in saying that columnar epithelium will form glands in microscopy? It does, right? So can I call it glandular metaplasia also? It's glandular metaplasia as well, right? There are three different names for Barrett's esophagus. What happens in exam is, see, people will scare you about an exam. Don't be scared. My job here for the next 6 months is to tell you, don't be scared of an exam. You get scared of an exam, You are defeated in the race already. You be very strong. You learn what is supposed to be learned. We'll see the exam. What maximum can be done in exam is 1 year it will be glandular metaplasia. Second year columnar metaplasia. Third year goblet cell metaplasia. Because no one in the exam or in your college is capable of creating a new disease. They are not. They will ask the same disease which is present for 200 years in a different way. That's all, right? So it doesn't mean there's a new MCQ. It's the same damn MCQ, same damn Barrett certificates, three different ways of asking them. That's all they can do, right? So we know about the etiopathogenesis. My GRD is my etiology. My pathogenesis, it changes like this. Again, we'll go to the same template. Etiology is done, pathogenesis is done. So I need my clinical features. Our goal is diagnosis. That's the only goal for you and me from now on, right? For my diagnosis, I need clinical features. What do you think will be the clinical feature of GERD? Simple. I told that acid burns esophagus. That's my clinical feature. The patient will have heartburn. MCQ will tell heartburn. If I have heartburn today, will it result in Barrett's tomorrow or it will require some time? Require some time, right? So an acute GERD for 1 or 2 days is not a concern for me. Chronic for years together is a concern, right? For years. Let's say like 2-3 years. I'm not mentioning years, but I'm just saying a longer time. Heartburn for a longer duration is definitely a concern, right? Perfect. Because an acute is not a problem for me, it will automatically get sorted. Heartburn for a longer duration, there's a chance it can become Barrett's esophagus. So I can understand that this is what's happening inside my body. But until and unless I see it with my eyes, I won't believe it. You have to see it to believe it. I know it's a heartburn, the GRD symptom also, so that the surgeon comes into the picture. The surgeon does an endoscopy. The surgeon puts an endoscopy to prove it is Barrett's and not just GRD. Okay? I'm having two lining here. One is squamous lining, which is normal. The other is columnar lining, which is undergone metaplasia, right? This is my concern. The squamous has become columnar. That's my main problem in Barrett's. Now put your pens down. If you're writing notes, put your pens down. Let's understand what this is. Squamous, other name is stratified squamous, right? Let's say that this is my squamous epithelium. Multiple layers. Columnar is single layer. Squamous is multi-layered. Both of the epithelium, can I say below my epithelium, I'll have blood vessels? Am I right in calling that both below my squamous as well as below my columnar, I'll have blood vessels? Yes, right? So these two are my epithelium. I am looking it from the top. Which you think will be, which blood vessel do you think will be easily visible? The single layered columnar blood vessel or the multi-layered squamous blood vessel? Which will be easily visible? Single layered columnar blood vessel will be easily visible. Multiple layers, I won't see the blood vessel easily, right? Simple logic. So can I say a columnar epithelium in my microscopy will be red, in my naked eye will be red in color, and squamous epithelium is multi-layered and it will be pale in color? Is that statement right? It's right, right? Simple logic. My squamous is multi-layered. When something is multi-layered, the underlying blood vessel will be, I'm just writing blood vessel, will be rarely visible or less visible. I'm not saying invisible, I'm just saying less visible. But columnar epithelium is single layer and underlying blood vessel will be more visible. That's it. So now tell me, in naked eye, my columnar epithelium is going to be red in color, and my squamous epithelium is not going to be red in color, it will be pale in color, right? So in endoscopy, what happens is my squamous epithelium will be pale in appearance. My columnar epithelium will be red in appearance. When the surgeon puts an endoscopy, there will be a place where my squamous, pale squamous becomes columnar. An MCQ is originated there. So in other words, I'm writing B for Barrett's esophagus. The endoscopic finding for Barrett's esophagus is red velvety mucosa. You don't want to read for MCQ. You learn medicine, MCQ will automatically get sorted. Why velvet like? Because columnar epithelium secretes mucin. Mucus is shiny. So when a question says red velvety mucosa in the esophageal endoscopy, Barrett's is the diagnosis. When the surgeon sees red velvety mucosa in my microscope, in the endoscopy, think of Barrett's. But again, I need proof. Proof is always in pathology. Right? evidence should be there, because a surgeon might not, in the along with the mucus, he might misthink red and pale color, right? So obviously the next step is the surgeon takes a biopsy. The surgeon takes a biopsy. I'm going to see something in microscopy, but there's a gap here. I'll tell you why anatomy is also important to become an amazing doctor. Generally, we feel that we'll lead in the final year, we'll become amazing doctors. No, basic science is very very important, because let's say, let's see if you accept with me, stomach and esophagus, right? Let's assume this may normal JE junction. Am I right in saying that the cardia of the stomach has columnar epithelium? Yes or no? Cardia of the stomach, columnar or not? Yes, right? Esophagus squamous. So in other words, am I right in saying that? Am I right in saying that this JE junction, if a biopsy is from JE junction, it'll have both squamous and columnar? Is that statement right? That statement is right. It'll have both squamous and columnar. Correct, no? It'll have both squamous and columnar. So if a surgeon has by mistake taken a biopsy from JE junction, will it look same like Barrett's esophagus? Squamous and columnar. That's my concern. So that's where my anatomy comes. If you remember in anatomy, you must have read about constrictions in esophagus, surface anatomy. The JE junction, sorry, the JE junction is at 40 centimeter from incisors. Okay? It's at 40 centimeter from incisors. So that is what is very important for me. You put the endoscopy will have markings. When you see the red velvety mucosa above 40 centimeter, which means it is Barrett's. Let's say that around 35 centimeter, I'm having red color mucosa, abnormal. In an adult, only at 40 centimeter from incisor, JE junction will come. And JE junction will definitely be red and velvety only, right? Sorry. Okay. So that's very important for me. Never forget whatever you read. If it has an application, you have to read. No application, ignore. Forget. It's not a problem at all. So I need this microscopy and I need the biopsy well above 40 centimeter. Now microscopy came to me. Very simple to diagnose. I'll show you the image, you will diagnose it, right? It's not difficult at all. Difficulty is there in the mind. I'll show the image, I'll come back to it, right? This is my microscopy of the 35 centimeter biopsy, fine. I'm going to draw two things, one, and this is my two. This is my two. Now in these two images, tell me which is gland, one or two. Which is gland? It's simple. 2 is gland. So can I say 2 is columnar epithelium? It is columnar epithelium, right? Again, look at this. Look at this. Can I call this is nucleus? Whatever I'm circling here, can I call them nucleus? What color they are? Blue in color, right? So in other words, can I say this place has lots of nucleus or lots of layers? So what layer is this? What epithelium is this? Stratified squamous or single columnar? It is stratified squamous. So I'm having a stratified squamous epithelium here and I'm having an amazing columnar epithelium here. So if this biopsy is taken above the JE junction, my diagnosis Barrett's esophagus. You don't want me to explain pathology to you. I just want you to trust yourself. You have an amazing first year knowledge. Apply that. Don't get scared about the exam. Don't have pressure about an exam, right? It's my columnar epithelium here. You know it's a gland. Everyone here, I'm 100% sure you can identify gland. Everyone here can 100% say it's multiple layered. Everyone will definitely understand the history of GERD. And everyone, when it looks in endoscopy, you will definitely be able to say which is stratified, which is columnar, which is squamous, which is columnar. This is an endoscopy finding. There's an endoscopy here. I'm betting on you 100% everyone can say which is columnar, because columnar is single layer which can see the underlying blood vessels clearly, so it's red in color. Red color, this is my normal squamous epithelium's color, right? So this is my columnar epithelium and this is my squamous epithelium. That's how it looks in your Barrett's esophagus. My endoscopy of Barrett's, visible, easy to diagnose. My microscopy of Barrett's, visible and very easy to diagnose, right? I know everything about Barrett's esophagus. Yeah. Now tell me, which is more comfortable for me to report? To say it is gland formation Or to say it is having mucin formation, which is more comfortable for me, gland or mucin? I know microscopy you'll see both glands and multi-layered squamous epithelium, right? Tell me which is more comfortable for me, to call something and say that there is only glands available or gland with goblet cells available. Gland with goblet cell is more important, right? Because goblet cell is more important and diagnostic point for me here, not just gland. Because cuboidal epithelium can also form glands. Yes, right? Cuboidal can also form glands. What is important for me is glands plus goblet cells. The function of goblet cell is to produce mucin. Yes. What is the color of mucin in microscopy? The color of mucin in microscopy. Think well and answer. You need not be an amazing genius to answer this. You just need to be a normal human being to answer this. Color of mucin in microscopy. You must be wondering, right? I have only three colors: pink, blue, or clear. Have you seen mucus in naked eye? You must have. Don't say you are not seen. You have seen everything. You have lived for 20 years. You have seen everything in life. Have you had running nose? Yes. Mucus comes from the nose, right? Color of mucin? Clear. So mucin in microscopy also will be clear. That's all. Perfect. So my mucin in microscopy also will be clear. Now going back to a thumb rule, who was the other person who was clear apart from mucin? Thumb rule said that blue is DNA RNA, pink is rest everything, clear means fat. Now tell me, is it possible for me to say the clear area is due to fat or mucin with normal microscopy? I can't, because both fat as well as microscopy, as well as mucin or water, everything will be clear. So I cannot differentiate what is causing the clear area. So that's where I need special stain. Remember this concept is very, very important. I need to know the utility of a special stain. Why do I need it, right? The simple solution here is, if you cannot differentiate or cannot identify on a light microscopy or on a HNE, I need special stain. That's all. Anything. If I cannot differentiate something on a HNE, okay, this is that, I need a stain. If you can differentiate, you don't want a stain, right? The special stain here is two stains. I want you to remember this. This might not be given in Robbins in the first chapter. It might be given somewhere else, but it's important for an MCQ point of view, right? I have two stains here. I have Alcian blue and I have PAS. Okay, PAS makes the mucin magenta pink in color. It stains the mucin magenta color, and Alcian blue, like name says, it'll stain the mucin blue in color. So fat will not be stained by PAS or Alcian blue. So once it's stained, I'll be more than happy to call it, okay, this mucin positive goblet cell as a Barrett's esophagus, right? As simple as that. Now, see, again the same thing. I know the etiology, I know the pathogenesis, I know the way to diagnose, I know the clinical feature, I know to confirm. The next thing is treatment. Treatment, I will never talk about treatment because I'm not the right person to talk about treatment. You are better than me in talking about treatment, right? Treatment is simple. The problem is excess acid production. Treat with antacid, someone said, right? Omeprazole, proton pump inhibitors. If it becomes worse, maybe do a surgery, right? So I know everything. So now my only problem here is complication. Again, I'm going to ask you a simple question. Let's say that Sahil, musicarmine is not useful for this type of mucin. It's useful for salivary gland mucin, right? You're right in saying it's musicarmine. PAS is periodic acid stain. Jane, fine. Why about this stain might not affect my epithelium, because in a goblet cell, entire epithelium is filled with mucin. It will not affect the nucleus. It will have the same color. Only when there is mucin, it becomes magenta. Only when there is mucin, it becomes blue in color. Fine. Okay. So now my complication is very important. Can I say, if I'm not able to take care of GERD for the next 10-15 years, is there a possibility it can become cancer? Yes. Any possibility? Yes. What cancer will it become? What cancer will it become? No, but only when it's mucin, it like impart a color, fine. It'll become adenocarcinoma. Okay, because it becomes a carcinoma from columnar epithelium which form glands. Any gland forming carcinoma, I call it an adenocarcinoma. That's all fine. So this leads to my MCQ. The most common carcinoma in the lower third of esophagus. In the lower third of esophagus, I have Barrett's, and the most common carcinoma is adenocarcinoma. In the upper third, I don't have Barrett's, and the normal lining epithelium is squamous. What's the most common carcinoma in the upper third and the middle third of esophagus? Squamous cell carcinoma. That's all. Normal, right? So upper and middle third doesn't have Barrett's, so it forms squamous cell carcinoma. Lower third has Barrett's, forms adenocarcinoma, right? These are not most commons. Just remember that's how it is. It's a fact. That's it, right? So we know about Barrett's, everything, right? Once you know about Barrett's, we'll come to the second thing. Normal respiratory mucosa. Okay. We'll take a normal respiratory mucosa. We'll try to understand what happens in a respiratory mucosa. Fine. Let's say a person is smoking forever. You must have seen people who smoke, right? Like chimneys. There's nothing called acute smoker, chronic smoker. Every smoker is chronic. Every alcoholic is alcoholic. There's nothing called an occasional alcoholic. Alcohol is alcohol, smoking is smoking. That's it. Right? You're very young, you'll have lots of peer pressure. Don't listen to anyone. Any day, 100% both smoking and alcohol is hazardous to health. Fine. Okay. Let's say a person smokes. Smokes goes into the respiratory tree, right? The normal respiratory mucosa has your ciliated columnar epithelium. Okay, stratified ciliated columnar epithelium. You must have definitely known this, right? It's a ciliated columnar epithelium. Cilia. The cilia will be destroyed by smoke. The smoke destroys cilia. Same problem. So I need an epithelium which is resistant to smoke. You are living in India. Am I right in saying that my full environment is full of smoke? Not just India, any part of the world, most part of the world, environment is full of smoke. My skin daily is looking at smoke. Nothing is happening to my skin because skin is very, very, very resistant to smoke. Maximum it will become black in color. Wash it, it goes away, right? So what my body knows that smoke can be tackled by a squamous epithelium. So it produces squamous epithelium, and I call this an squamous metaplasia. Okay, that is squamous metaplasia. If a person continues to smoke, the metaplasia is reversible. If the person continues to smoke, is there a possibility that it can become cancer? If so, what cancer? Squamous cell carcinoma, right? If the person is not going to stop smoking, still smokes forever, it will become squamous cell carcinoma. I'm writing SCC for squamous cell carcinoma, right? So now tell me, with your logic, and you've lived for 18, 19, 20 years, right? Just with your logic, tell me which is more common, GERD or smoking in your real life. Don't consider the textbook at all. Which is more common, GERD or smoking? 100% smoking is more common, right? So this 100% is the most common example of metaplasia, right? It's the most common metaplasia because 100% smoking is more common than GERD. That's the most common metaplasia here, right? Understood? Clear? Perfect, right? So that's why don't read most commons. You know, in real life, you know, you've been living your life, right? Definitely smoking is more common, and 100% smoking is the most common. And this metaplasia is the most common metaplasia, right? You know what one metaplasia? I'll give you more examples. See, because metaplasia, whatever we are lit, is a template. I can apply that in multiple places. One important thing is vitamin A. You must have read about vitamin A in biochemistry for sure. Am I right in saying that vitamin A is one important thing for epithelial maturation or any maturation? For the example, vitamin A helps in maturation, right? You must have read about vitamin A and vitamin A deficiencies, everything in your biochemistry, right? Vitamin A helps in maturation. That's one of the functions, right? So when a person has vitamin A deficiency or vitamin A excess, can I say both deficiency and excess will alter maturation? Is that statement right? Vitamin A helps in maturation. Both deficiency of vitamin A or excess of vitamin A will affect maturation? Yes. If it affects maturation, both of them will cause metaplasia. Both will cause metaplasia, not just deficiency. Both excess of vitamin A and deficiency of vitamin A can cause metaplasia. Remember that. That's a unique thing about vitamin A. Both excess as well as deficiency, both of them will cause metaplasia. I'll give you one simple example which I'm sure you can relate. You must have heard about in your vitamin A deficiency, in your biochemistry. I'm sure you must have heard about this. Have you heard about something called as Bitot spots or keratomalacia? You must have heard about, right? For sure, you must have read about them. Keratomalacia and Bitot spots. It's nothing but metaplastic areas. The cornea is generally transparent. If it becomes keratinized, skin is keratinized, is skin transparent? So will it affect my vision? It will. Bitot spot seen in vitamin A deficiency, keratomalacia seen in vitamin A deficiency is nothing but a metaplastic change. If this is true, is this reversible? It is reversible. If the cornea is not completely damaged, if it's partly damaged, I can give vitamin A, I can treat with vitamin A, and all of them will come back to normal. The only goal for me is the outcome. If it's not related to outcome, don't remember it at all. I know keratomalacia and Bitot spots are metaplasia, and I know every cellular adaptation in the world is reversible. It will definitely come back to normal, right? Zero of them, anything, it'll come back to normal, right? Okay, perfect. Next, let's take bladder. What's a normal epithelium of bladder? Can anyone tell me the normal epithelium of bladder? Normal epithelium of bladder mucosa is transitional epithelium. Okay, it's transitional epithelium, right? This normal epithelium is transitional epithelium. Let's say a patient has a bladder, you have the prostate, and you have the urethra. And I'm having a stone here. Maybe the bladder neck or in the urethra, I'm having a stone. Yeah, I'm having a stone. Yes, Sal, you're right. I'm just coming into that. I'm having a stone in one of the bladder outlet. So the stone is irritating my bladder mucosa. Is there a possibility that this will change to something else? It will change, and always the most resistant epithelium is squamous. It will become squamous epithelium. The entire body, the most resistant epithelium is squamous. Skin is squamous. You hit, you scratch, nothing happens to my skin. You scratch with the stone, also nothing happens. So my transitional epithelium might get injured due to the bladder calculi. Like Sahil said, it's not just bladder, salivary gland also, allolithiasis, cholelithiasis. Anywhere when there's a lithiasis, definitely that can damage my mucosa. And everywhere it changes to my most resistant epithelium, which is squamous epithelium. Fine? Yeah, that's all. Bladder can have, your gallbladder epithelium can have, your salivary gland epithelium can have in response to stone. Right? I don't want you to remember everything. It's lithiasis. Lithiasis stone. Wherever there's stone, I can have squamous metaplasia. Right? So can I say, if I'm not removing the bladder calculi, is there a tiny bit of possibility that squamous epithelium metaplasia can become a squamous cell carcinoma? Yes or no? Just comment yes or no. Okay, is a squamous metaplasia. If I'm not able to remove the bladder calculi, is there a tiny bit of possibility that it can become squamous cell carcinoma? Yeah. So I call bladder calculi an etiology of squamous cell carcinoma or a risk factor. Anshuman, stratify. It's a stratified squamous epithelium, fine. Okay, it becomes a risk factor. Bladder calculi is definitely one of the risk factor for your your squamous cell carcinoma of bladder, right? Again, you remember one, always relate to my template. It has to fall in the template. If it falls in the template, I will read. If it doesn't fall in the template, I won't read, right? So whatever we have learned till now are examples for epithelial metaplasia, right? We'll just take a example for mesenchymal metaplasia. Okay? One simple example for mesenchymal metaplasia, which most of you can relate easily. When you have a fracture, what's the first step of a fracture? You fall down. I'm having a beautiful bone. I'm going to read all about the bone, right? not a very good bone, but there's a bone, right? So after, when there's a fracture, it automatically breaks, right? The bone breaks, right? So can I say whenever the bone breaks, there's definitely a possibility there'll be a blood clot here. There will be a blood clot here, right? I'll have a blood clot here. Can I say this blood clot is where all the growth factors will be present for a new bone to form? In this blood clot, you'll have all the growth factors for new bone formation. Am I right in saying that? Yes, right? I have this. Yeah. Vaibhav, I'll come to it. I'll come to it. I'm not able to see the comments. Why? However, kidney stones will be always symptomatic, so it will be treated. Bladder calculation is one which might not be symptomatic, so there's a chance of metaplasia. Kidney stones might not cause metaplasia. Right? Okay, coming back to this. So this place is where I'll have all the growth factors required for new bone formation. Normally, what you do is after a fracture, you put a slab, you immobilize the area. If this bone is fractured for me, I will immobilize. Once I immobilize, the clot will be stable. But there is, after fracture, when the person goes for a native treatment. When I say native treatment, anyone who treats fracture who's not an orthopedician is a native treatment. I'm not demeaning native treatment, but yes, they don't have a proper science. I have more applied science, that's all. So if you have ever seen a person having a fracture, in native treatment, what they do is they put oil, rub the area like this. Once they rub the area, am I right in saying that I will dislodge the clot? You will, right? Native treatment, they dislodge the clot. When the clot is broken, am I right in saying that this growth factors in the clot will automatically move to the surrounding area? Yes, the growth factors moves to the surrounding area. When the growth factors move to the surrounding area, am I right in saying that the growth factors might, are you guys able to comment? The growth factors might form bone in a muscle, because surrounding area is nothing but muscle. Surrounding a bone, I have muscle, right? So can I term this as myositis ossificans? In the muscle, I'm having bony tissue, right? In the muscle, when I have bony tissue, I call it a myositis ossificans. Perfect. That's also a metaplasia, an example for a mesenchymal metaplasia, right? Okay. So I'm sure you were able to link to the types of metaplasia. I hope you guys are able to comment because I am not able to look at your comments. Sorry. Okay, that's an example for a mesenchymal metaplasia. This mesenchymal metaplasia will not progress to a cancer, right? Most of the other epithelial metaplasia, there's a chance of progressing to a cancer. Here, it will not progress to a cancer, right? Okay, so I'll stop the class with this. The other adaptation atrophy, I'll start it from tomorrow. Just we have one more atrophy, and maybe after that we'll look at few MCQs and we'll solve MCQs, right? So just to cover what we've seen hyperplasia, we've seen hypertrophy, we've seen metaplasia, fine. You have that? Okay, atrophy is one more cell adaptation. We'll definitely see it tomorrow. Uh, I'm not okay. I'm not saying that go and read today, but at least you'll have the PDF or something. You'll have notes. Just once you will definitely have your dinner, or you must have be having your dinner. Discuss difference. The learning in medicine comes with discussion and teaching to another person. Teach to your friend. The friend learns it. The friend asks you a question. You come back and you learn more. Right? Okay. So thank you for your time. We'll start tomorrow, and I hope my internet will not cause trouble tomorrow. I'll be able to complete the cellular engineering tomorrow. Fine. If you have any more doubts, you can ping me on Telegram or you can ping me on the PW Telegram group or my Telegram group or Instagram, right? I'll be more than happy to help, right? Thank you for your time. Thank you for your valuable comments and inputs. And if you have any more queries regarding PW, do let me know. Thank you. Bye bye.